And I'm here to open that unique event, a very inspiring event. As a researcher, I'm part of the Brazilian Society of Neurosurgery. I am a professor of Atenas University and a researcher at the University of São Paulo. Professor Sérgio Mascarenhas was an enthusiast of my work, so he has always been very supportive, especially in a very complex, challenging country for research. So thank you very much for the organizing committee, especially Brain Care, which has supported this event, bringing together some of the main researchers on pulse pressure and intracranial pressure. You're going to see a number of challenges presented in my talk. Some concepts have changed throughout times. For many years, this was not clear-cut. And we will see that the main changes really started 30 years ago. And 10 years ago was effectively the time when we started to talk more about intracranial pulse pressure. So Columbari, great organization. I would also like to thank all speakers who are going to follow me. All of us here for free, spontaneously, providing universal access to science. And this has always been the reason for living of Professor Sérgio Mascarenhas. This is his main legacy. A complex situation was transformed into an inquiry question and then translated into simple ideas to be shared with everyone. We used to have data about intracranial pressure to just few patients, and now we have that widely acceptable. We really have to understand the context about intracranial pulse pressure. This was a publication made last year. For nearly 200 years, we've been trying to monitor intracranial pressure to reduce mortality, especially in neurosurgical and neurological diseases. This has been studied by different specialists in the area, but the history dates back from Monroe-Cayley doctrine, and we are going to understand some situations from the manuscripts. The study started from checking the database about intracranial pressure, cerebrospinal fluid pulse, monitoring. So we've brought a whole understanding of that. Monroe lived between 1733 and 1817, which was reported by James Health. Professor Monroe was from the UK, where he started his main experiments, investigating primarily the structure of the nervous system using comparative anatomy. The brain included more than compartments, and his main contribution was published in 1783. Observing the structures and functions of the nervous system in illustrated tables. And Monroe's understandings were: the brain tissue volume is static, and we're going to talk further about that later. There are compartments in the brain, including blood, arterial, venous, CSF, and brain mass. The volume would be impacted if any of the compartments increased in size. Monroe participated of the discipline in the University of Edinburgh, Together with George Kelly, who lived in 1770 to 1829, they carried out autopsies together and started observing all patients and trying to understand the mechanisms. Physiologists carried out experiments involving venous and arterial systems. They wanted to understand the brain compartments, which were static in their opinion, trying to understand the cerebral circulation. Kelly has drew some different conclusions. The skull is a firm, inflexible structure, primarily in adults. We know in children, the bones are still somewhat more malleable. That were the theories at that time. The skull in isolation had a pressure mechanism, and depending on compartments and changes, the pressure could go up, and blood volume inside the skull could vary. Increasing pressure could, as a consequence, reduce blood flow, leading to ischemia and subsequent compromises. It's an old doctrine that remained a reality for many years, and we still teach this doctrine and concepts till today. However, today we have an adapted understanding of that, especially concerning new theories, including the one by Professor Sérgio Mascarenhas. John Abercrombie lived between 1780 to 1844. He was also responsible for disseminating the doctrine of Monroe Kelly. They wrote the doctrine and the disciples disseminated it. Here we have a book which was published in 1828, Pathological and Practical Research on Disease of the Brain and Spinal Cord. And the author reinforced the role of reducing blood flow and the possibility of compressing brain tissue. Therefore, we should always understand the contributions of different generations, even before Christ, for you to have an idea. There were some descriptions of brain flow since the Egyptians. So we have some information about CSF and the influences on intracranial pressure. 100 years after Christ, there was this understanding, especially described by Galilean, about the production of CSF. In Middle Age, during a time in which there seemed to be no history in science, anatomists believed that cerebrospinal fluid would only exist after death. Then during Renaissance, a number of anatomists were really studying and investigating, and then they got into circulation of, understand the circulation of CSF. Domenico Contugo described about CSF and different spaces in 1784, which was absolutely essential for our understanding of the process. And in 1842, you can see the main discoveries were in these years between 1784 and subsequent years. So imagine they defined that CSF had a unique physiology, and there were different compartments within the skull. George Burroughs in 1846, so you see 100 years later, reformulated the Monroe-Kelly doctrine. He emphasized a number of points and stated that the skull was a sphere, a firm sphere. But Burroughs described the influences of blood flow, the influence of the compartments, including CSF, did make a difference. If the patient had an increased pressure, the pressure of the liquid would have really a difference. And it has really been followed by a number of them. One of the reports, some of the contributions, that the increase of intracranial pressure could have impact cerebral vascular circulation, showing that CSF absorption, especially in its normal flow, could be really impacted. So as you can see, we have here a number of experiences trying to reinforce the control of intracranial pressure and its understanding. Berger has shown that CSF had an elastic function in the spinal canal and in the brain. Theodor Kocher, now going to 1917, established that intracranial pressure is the first stage of elevation for brain flow, leading to cerebral abnormality. So we can see some progression. Increased pressure will impact compartments, and intracranial pressure is an essential point to understand exactly when there is any breakdown to this balance. Harvey Cushing, the father of neurosurgery, has consolidated all the information, and he started naming disease by clinical manifestations. There used to be a rigid doctrine of compartments, inelastic skull. But then in the 1900s, thanks to the technology of that time, they understood better and could associate what was going on in the brain. Intracranial pressure was increased, correlating that with the clinical manifestations. Lewis Sweet, who lived up to 1952, stated that the brain volume had a variation according to the patient's status. It was not something static. It depended on the environment, clinical status of the patient. So as you can see, clinical manifestations and the physiological observations were correlated in trying to understand intracranial pressure increase. Professor Sérgio Mascarenhas in 2012 questioned the following, and I think this is the key point. Monroe-Kelly described the compartments, but the skull is not that rigid. It does have some degree of elasticity, flexibility. So Professor Mascarenhas showed that it's possible to identify intracranial pulse because a catheter was required first to measure that. It had to be fully closed to be measured. And the cranial and the skull, using a sensor, would have the measure of ICP. So as you can see, I'm here to talk about the disruption in history. Everything is to be considered static, stiff. In 2012, the publications by Professor Mascarenhas showed some movement of the skull. Internal cerebral influence on the skull could be measured through electrodes and sensors, which captured the information. We no longer needed intracerebral catheters to measure that. We could use a mathematical algorithm of the skull. So the minimum expansion of the brain would lead to changes. So using external sensors, we could understand what's going on inside the skull. This was extremely important because in my understanding, only patients, highly selected patients, could really have that pulse pressure studied. So I would say that 2012 was the main turning point for neurology and neurosurgery, because we could start studying that not only for critically ill patients, but also in all patients. So Professor Sérgio Mascarenhas has disseminated the knowledge and could do that, providing access to everyone.
But that's not all. In 2012, he thought, what can I do with such an information? Several researchers, they studied to be able to understand that there is a curve, not figures, not a value. What does that exactly mean in our brain? So our goal was to better understand what ICP waveforms were, P1, 2, and 3. P1 translates the heart systoles. P3 will translate the diastolic pressure of the heart. There is the strength which the heart makes, and that is captured by our brain because our body is made of pulsation, and we are able of capturing that. Our brain is a skull which is semi-rigid, according to Professor Mascarenhas' concept, is quite malleable, and that can be translated by P2, which is the cerebral complacence. How much of that cerebral portion is soft or hard to perform such a pressure? So it works like a waveform, like stairs actually, wave formation, P1, 2, and 3. And with those stairs decrease, we can see that the wave is going down. And if there is an inversion, P2 higher than P1, that is a sign that there is a cerebral problem, and ICP is impaired and something should be done. There are several mechanisms. Maybe we have different compartments, cranial mass. So for the past 30 years, professors, they try to understand the ICP waveform history. Most trials, they were spread thanks to Professor Mascarenhas, who was a pioneer in the field of studies and researches, and that became a landmark in our science because we are able to test it in all patients. And in the past 5 years, several researchers were able to test such a technology at different settings, clinical and neurological diseases at different rates, and also to be able to translate that curve and to perceive that such a curve may change according to the patient's clinical conditions. It may change from week to another. And today we have Professor Mascarenhas' data to be enhanced and updated. And to conclude, I'd like to say that we have two important times in history. We have Maura Kelly doctrine, which is a result of solid studies over 200 years. And now we have Professor Mascarenhas with this new way of understanding and interpreting ICPs. And throughout the day, you'll be able to hear several researchers and Professor Mascarenhas followers with different solutions and different ways to apply results regarding ICPs. The science now has new horizons ahead, and the history is not over. Let's keep studying and learning. This is my final message, and thank you so much for your participation. This is an opening talk where we are celebrating Professor Mascarenhas. The invitation. Thank you. Thank you, Nicholas. Thank you, Dr. Nicholas. What a great honor to have you here in this opening session. And Professor Mascarenhas, as always, has really broken such a paradigm. So I have a question. What is your opinion about the use of non-invasive sensors, not only in hospital admitted patients, but also patients in a medical office? They have their blood pressure measured in a non-invasive manner. Would you say that it would be a good idea to have at least the morphology of the ICP curve registered at a medical appointment? Well, I'll try to be very brief. Today, we realize that there are two main values in all services. The first one, time to be managed, and second, data. If we have data, we have the source to all sort of researches. Today, in my clinical practices, I perform in all patients the pulse measure and ICP. Today, I cannot consider anymore applying Professor Mascarenhas' technique in my daily routine because I have to understand other tests such as MRI, ECGs, and today, once I am able to combine the clinical measures, ICP and pulse, if I have two coincident results, that works as an alert. If I have just image tests or clinical tests, if there was any sort of divergence, I wouldn't be able to pick that up. But the pulse measurement, it's very helpful because it tells us about the clinical status of our patients. And most of the time, patients, they underestimate their findings, their symptoms, they get used to their symptoms. And the P1, P2 relationship is extremely high, and patient is right in front of you, and you think, well, the patient is not doing fine, he's kind of used to the disease. So the pulse measure is key in your clinical setting, clinical and neurological. Thank you for your answer, Dr. Nicholas. We have to close the session.